Hello, and welcome to this Enclave peer exchange entitled Advances in the Treatment of Malignant Melanoma. I'm Dr. Jeffrey Weber. I'm from the Laura and Isaac Perlmutter Cancer Center at NYU Langone Health here in New York City. Joining me today in this virtual discussion are my colleagues, Dr. Sunandana Chandra, who's from the Robert Lurie Comprehensive Cancer Center at Northwestern University in Chicago, Dr. Adil Daud, who's from the UCSF Helen Diller Family Comprehensive Cancer Center in San Francisco, Dr. Jason Luke, who's from the UPMC Hillman Cancer Center in Pittsburgh, and Dr. Ryan Sullivan, who's from the Massachusetts General Hospital Cancer Center in Boston. Welcome. Today we're going to review the latest data on melanoma released from the 2020 ASCO annual virtual meeting. And let's get started on our first topic. The first topic talks about perioperative approaches to melanoma. And a question that many of us medical oncologists deal with is, what's the optimal approach to the sort of the multidisciplinary management of locally advanced melanoma? So Ryan, tell me, how do you folks at your institution handle the multidisciplinary management of the disease?
Thanks Jeff for the introduction, and it's great to be here with such wonderful colleagues. One of the key parts of managing patients with early stage and high-risk melanoma is the multidisciplinary approach. I think there are three critical team members in terms of patient-facing, and that would be the dermatologist, the surgical oncologist, and the medical oncologist, and then a number of other critical people as well, including the dermatopathologists, our radiologists, and of course all the support teams that help out our patients. What we tend to do at Mass General is we sort of have a two-step approach. The first step is a dermatology, surgical oncology clinic who meet patients who are newly diagnosed with melanoma, and then we have a review at a multidisciplinary tumor board, and then typically a surgical oncology, medical oncology appointment that's jointly visited. So, you know, it's a little spin on the traditional multidisciplinary clinic where all of the patient-facing doctors are seeing the patient, but that's typically how we do it. And then we discuss the great majority of our cases, certainly any case where there's a question of what's the best management, and then move forward. I'll also mention that in the time of this COVID crisis, we've found that these have been immensely helpful because when we're maybe making a slight change to what would have been the standard of care in the setting where we have open ORs, if there's limitation to that, it's allowed us to apply novel approaches that have certainly support in literature to move forward with something that may not be sort of standard of care by NCCN guidelines.
And in your discussions with your surgical colleagues, how have those MSLT2 data, which frankly are now a couple of years old, how have they changed the extent and the role of the completion lymphadenectomy at your institution?
Yeah, for a few years before that, we were very often discussing the value of whether in a patient who had a positive sentinel lymph node, whether completing the lymph node dissection was appropriate for individual patients. A few years before the MSLT2 data came out, there was data from a randomized trial in Germany, which randomized patients with a positive sentinel lymph node to either completion lymph node dissection or monitoring with serial ultrasounds and exams, which found that there was no significant overall survival difference or distant metastasis-free survival difference between patients randomized to observation versus surgical complete lymph node dissection. And I think what was important about that, though, there was a lot of trouble with that study in terms of powering. From a statistical standpoint, it did prove the principle that there are probably some patients we don't necessarily need to do the completion lymph node dissection. You know, a year or two later, when the data came out, almost overnight. I mean, it was data that was just directly published in New England Journal that had never been presented before. And I remember the week before in Tumor Board, we were talking about doing completion lymph node dissections, and the week after, we were talking about never doing another one. And so there are some scenarios where a completion lymph node dissection may be considered. Certainly, if there's a palpable node, that wasn't part of the MSLT2, and those patients deserve a complete lymph node dissection. But in patients with positive sentinel nodes, it is the rare exception when we in concert with our surgeons, recommend a completion lymph node.
And let's ask some of our other colleagues. I assume they have the same philosophy, but how do you folks monitor the lymph node basins when you haven't done a completion lymphadenectomy? Adil, what is done at UCSF?
We use ultrasound to monitor the lymph node basin. And I think just like Ryan mentioned, when that DCOG study came out that was, I want to say ASCO 2015, we essentially stopped doing completion lymph node dissections. I mean, I've always thought it's a staging, that sentinel lymph nodes are a staging tool, not a disease control tool. So I've never really thought that any of these studies would show like a benefit unless you'd have to think that you're doing disease control from completion lymph node dissections. But there's been really no evidence from the WHO trials, a long time ago, which maybe many of you don't remember, but it was like 20 years ago or so. So to me, the whole sentinel lymph node biopsy, completion dissection, it's been more a diagnostic issue. And so we basically monitor people lymph node basins every 6 months with ultrasound if you're not doing scans on those patients.